If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome. I'm Fernando, a GP in the UK. In today's episode, we'll go through the updated NICE recommendations on the diagnosis and management of cluster headache, focusing on what is relevant in primary care only. It is based on the NICE guideline on headaches, or CG150, and the link to it is in the episode description. Right, let's jump into it. Cluster headaches are a primary headache disorder. Let's remember that we classify headache disorders as either primary or secondary. The cause of primary headaches isn't well understood, so we group them by clinical pattern. The most common primary headache disorders are tension-type headache, migraine, and cluster headache. By the way, if you're interested in the updated management of migraines, check the corresponding episode on this channel. The link is in the episode description. Secondary headaches are due to underlying disorders including medication overuse, giant cell arthritis, raised intracranial pressure, and infection. Headaches are very common, and there's often concern about possible underlying causes from both patients and healthcare professionals. So firstly, let's look at when we need to consider further investigations or referral. The NICE cancer guideline says that we should suspect the brain or central nervous system malignancy in adults if there is progressive, subacute loss of central neurological function. We will refer them urgently for direct access MRI scan of the brain to be done within 2 weeks. Alternatively, we can refer for a CT scan if MRI is contraindicated. In children and young people with newly abnormal central neurological function, we will arrange instead a very urgent specialist referral, that is, an appointment within 48 hours. There are some headache features that should also instigate further investigations or referral. The list is long and it includes symptoms such as worsening headache with fever, sudden onset headache reaching maximum intensity within 5 minutes, new onset neurological or cognitive dysfunction, head trauma within the past 3 months, headache triggered by cough, sneeze, or exercise, or an orthostatic headache, that is, a headache that changes with posture. Additionally, we will consider further investigations or referral for people who present with new onset headache and compromised immunity, a history of malignancy, or vomiting without other obvious cause. Once secondary causes of headaches have been excluded, then we'll know that we're dealing with a primary headache. But how do we differentiate cluster headache from other primary headaches, such as migraine or tension-type headache? Well, we will diagnose it according to the headache clinical features. So let's have a look at these features and compare them with what we would expect to see in migraine and tension-type headaches. Let's start with the pain location first. In cluster headache, the pain location is unilateral, usually around the eye, above the eye, and along the side of the head or face. In migraine, it can be unilateral or bilateral, and in tension headache, it is usually bilateral. The pain quality in cluster headache is variable. It can be sharp, boring, burning, throbbing, or tightening. In migraine, the pain is usually pulsating, although in young people it can also be throbbing or banging. And in tension-type headache, it is pressing or tightening, and generally not pulsating. The pain intensity in cluster headache is severe or very severe, whereas in migraine it is moderate or severe, and in tension-type headache it is mild or moderate. When it comes to the effect on activities, there is restlessness or agitation in cluster headache. In migraine, it is aggravated by or causes the avoidance of routine daily activities, whereas tension-type headache is not normally aggravated by routine activities. And finally, the duration of cluster headache is usually 15 minutes to 3 hours, whereas in migraine it is usually 4 hours to 3 days in adults, but sometimes shorter, from about 1 hour in young people. In tension-type headache, it is usually anything from 30 minutes to continuous. Cluster headache also usually presents with associated symptoms, and we can consider them to help with the diagnosis. For example, in cluster headache, on the same side as the headache, we can find a red or watery eye, a swollen and or drooping eyelid, a constricted pupil, nasal congestion or a runny nose, and forehead and facial sweating. On the other hand, common associated symptoms in migraine are unusual sensitivity to light or sound, as well as nausea and vomiting. Additionally, migraine can also have symptoms of aura, which can occur with or without headache. Typical aura symptoms include speech disturbance, visual symptoms such as flickering lights, spots or lines, and partial loss of vision, and also sensory symptoms such as numbness or pins and needles. Generally, aura symptoms are fully reversible, develop over at least 5 minutes, and last 5 to 60 minutes. However, we need to remember that tension-type headache usually does not have any other associated symptoms. If we look at the frequency of the headache, we can classify cluster headache in either episodic or chronic. Episodic cluster headache has a frequency from once every other day to 8 times a day, with a pain-free period of more than 1 month. And chronic cluster headache is the same, that is, from once every other day to 8 times a day, but with a continuous pain-free period of less than 1 month in a 12-month period. And let's remember that both migraine and tension-type headache can also be episodic, when it happens fewer than 15 days per month, or chronic, when it is 15 or more days per month for more than 3 months. Let's now look at the management of cluster headache. And first of all, for people with the first bout of cluster headache, we should consider neuroimaging, discussing with or referring to a specialist if necessary. As the actual treatment for acute cluster headache, we will offer oxygen and or a subcutaneous or nasal triptan. Currently, nasal triptans are unlicensed for this, and the subcutaneous route is also unlicensed in under 18s. When using oxygen for the acute treatment of cluster headache, we will use 100% oxygen at a flow rate of at least 12 liters per minute with a non-rebreathing mask and a reservoir bag, and we will arrange provision of home and ambulatory oxygen. When using a subcutaneous or nasal triptan, we will prescribe a sufficient number of doses, bearing in mind that the attacks may be multiple and frequent, so the quantity prescribed may also be significant. We will not offer paracetamol, anti-inflammatory painkillers, opioids, ergots, or oral triptans for the acute treatment of cluster headache. What is the position in respect of prophylactic treatment for cluster headache? NICE does not actually specify exactly when prophylactic treatment should be initiated, but in general, we should consider prophylaxis if the patient has chronic cluster headache, if attacks are frequent, severe, or disabling, if there's a need to reduce acute medication use, and sometimes in episodic cluster headache, we can initiate prophylaxis early in a cluster period, ideally at the onset of symptoms, because even if the bout is expected to last only a few weeks, prophylaxis can reduce the frequency, the severity, and the duration of the attacks. NICE recommends verapamil as the only option for prophylactic treatment during a bout of cluster headache. This is at the moment an off-label use of verapamil, and if we are unfamiliar with its use for cluster headache, we should seek specialist advice, including advice on ECG monitoring. The BNF actually says that it should be initiated under specialist supervision. For cluster headache that does not respond to verapamil or during pregnancy, we should refer to a specialist. So that is it, a review of the assessment and management of cluster headache. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.